dialysis, then they go for transplantation. They go for transplantation. So now this transplantation works when the both kidneys, because the chronic renal failure means both kidneys are damaged, right? So now transplantation happens between the donor and recipient. Who is recipient?
Patient.
Patient. Who could be the donor? One
A
is
family member.
cadaver and the live family member, right?
Mhm.
So which one is more preferable?
Live family member.
Live family member. Say example, son can give to the father, father can give kidney to the son, right? Brother, sister.
I have a question.
Hmm.
If they're taking it off of somebody that passes,
Hmm.
then do they split the kidney and one go to one patient and one go to another patient?
No.
Or do they take both to this
No,
patient?
they will take one kidney.
Only one.
Transplantation is always
One.
one kidney.
Okay.
Okay, so now cadaver. Cadaver means dead body, right?
Mhm.
It has to be taken within 6 to 8 hours. But it should be noted that this cadaver who is dead, his blood group and histocompatibility matching, tissue histocompatibility must be matched. But most of the time it's an unknown patient. But if you know that somebody is matching with me and we are convincing him or her that can you give me a kidney, but suddenly something happened, he got road traffic accident, so now they can give the kidney, right? There is no problem. So then this kidney should be taken within a certain time. They found that if it is more than 10 to 12 hours, the kidney is dead, kidney tissue is dead. And when they get the kidney, either from cadaver or from the live, there are two different situations. When from the cadaver, so then the recipient, the patient, will be informed and patient will be taken to the hospital, right? So then when they took the kidney, this kidney will be cleaned as much as possible. There will be no gyrotous fossa. There will be no perinephric fat, only the renal capsules. And they will try as make it as minimum possible the tissue, different tissue. So then they will clean the kidney and followed by they will clean, they will clean blood clots inside the kidney. How? They will inject the normal saline through the artery and the saline will come back with the blood and blood clot through the vein. So in that way they will clean, then they will keep in the cold box. Because why they will keep it cold box? Because it will make the cells less metabolic activity. So cell will not die. You got it?
Mm-hmm.
Okay. So then patient will be informed and taken to the operation room. then they will keep the native kidney. They will place in the, usually they will take the left kidney. It is easy for replacement on the right side. They will replace the kidney on the right iliac fossa. They will not disturb the native dead kidney. You got me?
Mm-hmm.
Because they don't want to do the double surgery. They will keep it because they know this kidney will be dead. Just it will be dry up and it will be very small scar tissue. But this is the transplanted kidney. When they took the kidney out, not only the kidney, they take the renal artery, renal vein and the ureter. They will if they take the left kidney, they will take the left kidney along with the renal artery, left renal vein and the left ureter. So renal hilum is there, right? And they will put this hilum here. So that means anterior surface will be posterior, flipped. Okay, and they will connect the renal artery with the, on this right side, right common iliac artery or internal iliac artery, but they will connect with the common iliac artery and the vein with the common iliac vein. You got it?
Mm-hmm.
Now, and the ureter with the bladder. They will cut short the ureter and they will anastomose with the bladder. And this kidney will be held tight with the surrounding tissue so that kidney does not get rotated or torsion. And this kidney is superficial. Patient can feel it that there is something in here. It is placed just behind the anterior abdominal wall. If a children get the transplanted kidney from the adult, so that time the kidney will be connected with the aorta.
Okay.
Okay, will be connected with the aorta and the renal artery will be connected with the aorta. Okay, so now if this is the live member, so then in the operation room there is a bed, this live patient, and this is another bed with the patient. Okay, live donor. So donor they will take the kidney from the donor a little earlier than the patient's surgery, because there are two team of surgical. Okay, one will take the donor kidney out and they will process the restoration of the kidney. Mm-hmm. And they will make it ready. Then they will do the surgery of the patient. Both of them are in the operation room. Then they will replace this kidney into the patient. So now question, what is the sonographer's role? Sonographer's role is when the live family member is giving the kidney, so they have to do the examination of the kidney that is given to the patient, right? So donor's kidney must be checked. Why? It must be healthy. That's why they need to do ultrasound, they need to do the blood work. So kidney is healthy. No, not everybody can be a donor. If patient has an infectious disease, HIV, hepatitis B, hepatitis C, no way. If patient has cancer, no, that is not a good donor. A healthy donor is important. And they will be scanned, the kidney, okay? And both kidneys are fine. You have to look for the live patient. If they give the one kidney, they will not suffer from, again, with other diseases. No, they cannot. And there will be full consent. Sometimes you will see the third party there is no blood connection, they can be a donor too. But it takes time. So now, when the kidney is transplanted,
It's 3:15. Just want to let you know.
it's fine. I have to finish it.
Okay.
So now, transplantation. So now, patient, okay, sonographer's role. Sonographer's role. So, after transplantation, sonographer will do the baseline ultrasonography to know the volume of the transplanted kidney. To know the volume of the transplanted kidney, and they will do the renal artery evaluation, renal vein evaluation. Okay, they will see the anastomotic sites. They will look for any collection. Any collection. It could be blood, it could be urine, immediately. In the later, it could be pus, it could be lymphocyte, lymphatic fluids, any collections. Okay, so now, after surgery, every day, check out. So, usually by 2 weeks, transplanted kidney volume is increased by say 23 to 24%. Okay, almost 1/4 volume will be increased. If greater than 25%, this is sign of rejection. Okay, sign of rejection. So now, what is rejection?
If the body doesn't
Body did not
take it.
accept it. So rejection could be acute, subacute, and chronic. Acute means within 2 weeks. Subacute, within 2 to 6 months. And chronic, lifelong. That's why this patient is taking a steroid for lifelong to reduce the immune response. So when there's a rejection, that means our body immune system fail to detect it, that it could be accepted. No, they attack. So now, when there's a rejection, sign of rejection, what are the sonographic view of rejection? That is very important. Sonographic evaluation of rejection. Sonographic evaluation of transplanted kidney. Usually the evaluation is every day. Every day evaluation. They need sonographer every day. Sometimes in the morning and in the evening too. So what are the points? So now if the volume is increased by greater than 25%, okay, renal vessels flow is decreased. Renal cortex is hyperechoic and thicker. Renal pyramids, medullary pyramids are bigger and stand out. Fluid collection in the sinus and resistivity index is greater than 7. Okay? Greater than 7. So renal vessels flow. Renal arterial flow is decreased. You will see if it is your kidney and you get the kidney. So normally what happens? You will see the renal pyramids are stand out. So more darker because the cortex is brighter. And you click the renal artery, you see normally the artery is everywhere. You saw in the first day, artery is flow is everywhere. Flow is everywhere. But the next day or next week, you see the flow. You click the color, the flow is not everywhere equally seen. Some area is flow is intact, some area flow is deteriorated. When the flow is deteriorated, means less, what does it mean? The tissue of the kidney is dying over there. When the tissue of the kidney is dying, so it will be more darker. It will be more hypoechoic. You will see the patchy area in the kidney is more darker and there is no blood flow. There is no blood flow. So keep that in mind. Write down. There are 4 causes. There are 4 causes that cause the resistivity index is high. The renal resistivity index is high. Okay, one is number 1, hydronephrosis. Renal rejection. Renal tumor. And polycystic disease of the kidney. Okay, so that's all you need to know the kidney. So kidney, learn it more because you're going to get a lot of kidney patients. Okay, so if you have a good idea, the way I gave you the idea, keep it. Then you will see kidney evaluation is just 1, 2, 3. Okay, after kidney, so we're going to start doing the small structures, maybe the bladder next, then adrenal glands, so it will be better for us. And just keep reading and keep studying the materials that I am giving. Okay, thank you very much for coming in and also studying my handout. Okay, thank you, and I hope you're going to enjoy the kidney lectures and help me to record more lectures related in abdominal organs. Okay, thank you very much.